In this video, I attempt to do one of the most influential gamut metrics justice by discussing it from a survival flight perspective. In transport medicine, one of the most covered, taught, and scrutinized subject areas is airway management. But with all of the buildup, are we getting better at it? And what is the standard? Over the past 20 years, survival flight has modified its standard for airway success. Our measurement transitioned from a cuffed tube through the vocal cords within 5 minutes, regardless of number of attempts, to the idea that the tube needs to be placed on the first attempt. To this metric that still some folks just don't see value in. Well, here's the value. Say that you successfully placed an endotracheal tube on the first attempt, and as you look up to high-five your partner, you see this on the oxygen saturation monitor. So how successful were you? Successful enough to end up here on the oxyhemoglobin dissociation curve. That is why I will be spending the next several minutes explaining -1A. Definitive airway, sans or without hypoxia or hypotension on the first attempt, a metric developed by Dr. Bill Hinckley out of the University of Cincinnati with the simple idea that while we should strive to successfully place an endotracheal tube on the first attempt, considering patient morbidity and mortality risks increase greatly with each subsequent attempt, we should not do this at the expense of the patient's physiologic condition. So what has helped survival flight not only improve what our statistics look like, but our ability to more effectively and safely manage these critically ill and injured patients? While it isn't just metrics, it is a combination of advances in technology and broadening scope of practice, including increasing the number of medications in our RSI formulary, thus allowing us increased options based upon patients' physiologic status. Attaining the latest tried and tested video laryngoscopes, allowing us to meet and exceed current airway management standards. Focused training on the causes of hypotension and hypoxia in the critically ill, and adjusting our care standards to be able to address and mitigate these risks. A better ability to differentiate shock, thus allowing us to be proactive rather than reactive. And when speaking of mitigating specific risks for hypoxia, we've also employed the use of what's called apneic oxygenation into our practice. It's a very simple step that has proven to be very useful in preventing precipitous drops in oxygen saturation during laryngoscopy. So let's look at how we have done as a team over the last couple of years. We started utilizing -1A in early 2015. While we typically average about 10 airways per quarter, the third quarter of our calendar year seems to be the busiest with the highest volume. If looking at this table, I've taken our airway procedures for a specific quarter and have measured them utilizing the 3 different methods by which we have historically determined success. As you can see, if we wanted the numbers to look amazing and if we really wanted to feel good about ourselves, we would look at and advertise the first metric exclusively. However, with survival flight's interest in gauging our success and how we train to improve by what is best for the patient, in other words, avoiding hypoxia and hypotension, it looks as though we still have some work to do. Then again, most organizations submitting their data do as well, as the national average is somewhere around 65 to 70%. Removing an outlier from one bad quarter, notwithstanding specific circumstances surrounding these stats, survival flight is currently consistent with the national average. Good enough for us? Absolutely not, which is why we scrutinize each airway attempt, continue to perfect our procedures and practices, and make our measuring stick that much more restrictive.